Thank you, Dr. Abdulaziz, for the nice introduction. It's my pleasure to be with you, and I would like to thank the Scientific Organizing Committee to prepare for such great conference, updated us, and increased the awareness about the new guidelines in all of rheumatology disease. Early diagnosis of systemic lupus erythematosus. As we know that lupus, SLE, is one of the difficult, challenging cases we can face from the early starting and if the patient have complications. And early diagnosis may make your patient decrease the mortality, morbidity, and to have the high quality of life. So why lupus? Because again, as we say, that it's a disease of 1,000 faces. We have a lot of difficulty to diagnose the patient. We have lots of modalities updated in guidelines to treat lupus and to have the diagnosis. So what is lupus? It's a multisystemic autoimmune disorder of connective tissue disease characterized by autoantibodies that target the nuclear antigen, affect all organs, and have remission, flare, high variable clinical presentation, disease course, and prognosis. Here you can see that the epidemiology, the patients who are commonly affected, female, have predominant to male. African American and Alaska Arabian origin have increased prevalence. The incidence, as you can see here, we can see 1 to 10 person per 100,000 person per year, and in the adults, and in the children, you can see from 3 to 8 per 100,000 children. So, what are the risk factors? Genetic risk factor are the increasing and have the high incidence. As you can see here, in the monozygotic twins, the dizygotic twins, the family history increased the incidence also. And here are the genes mutation that can lead to lupus. As you can see here, the interferon leukocyte antigen. So, environmental, starting by smoking. Why I wrote smoking at a big highlight? Because I spend, maybe as I'm discussing with the patient lupus, in each patient for autoimmune disease, I discuss the risk of smoking, that it may be the cause of the disease itself, may have the flare of the disease, and it may decrease the patient response to most of the medications. And in lupus, smoking, current smoking increased the risk, but not the history of smoking. And also anti-DNA, it increased with the smoking. Here, as you can see, we have to ask the patient what they are exposed to, silica, mercury, and sometimes if the patient have medical conditions that increase the risk of lupus, as endometriosis, stress. As we can see, that stress not only increase the risk of autoimmune, also the endocrinal, the cardiovascular, the strokes. So we have, as much as we can, educate our patient to relieve themselves from the stress, to prevent not only of the autoimmune, multi of the diseases, starting by simple depression, going to malignancies and oncology. Celiac disease, they also say that it may increase the risk of lupus. Antiphospholipid syndromes, sometimes we have in the clinic a lot of patients, they are negative ANA, anti-DNA, anti-Smith, but positive antiphospholipid. With screening after months, we will find that antibodies for lupus, it may come positive. Antibiotics as sulfur-related medication also can increase the risk, and metabolic syndrome also. But all these are undergoing trials and studies. So if I want you to take a home message, the picture that I want you to take it. This is why we have to early diagnose the patient with lupus, to prevent the morbidities as the joint here, and the skin rash simply, going to the irreversible complication, intracranial hemorrhage, or if the patient have mesenteric ischemia, that may increase the morbidity, mortality, and may lead to patient death. So these are the most common clinical manifestation the patient can present, okay? Inflammatory arthritis, you can see here, it started with 50%, malar rashes 49%, going to kidney involvement 13%. All of these percentage you have to know about it. And these also the complication that the patient may have followed for the 10 years. This was studied before. So how to make the diagnosis? So one thing you have to know that lupus is very challenging. It may come classical, and it may come atypical presentation, especially if you have young patient and he has not only lupus, positive history of any autoimmune disease, or if the patient have been exposed to something we don't know about it. So lupus have a diagnosis can come with heterogeneous clinical manifestation, antibodies, starting by the positive ANA and using the Euler ACR 2019 classification and the Silica classification 2012. So in this picture, this is we used to scale our patient, but we always have to put lupus as a differential diagnosis for serious cases. Sometimes you can diagnose lupus with antibodies, only ANA and biopsy, whatever the biopsy was from it. So here, to diagnose lupus, we can have the ANA positive. You have to put in your mind, the titer have to be from 1 to 80. You consider it positive and having one clinical manifestation by calculating the score for the cutaneous, the musculoskeletal, neurological, serositis, hematological, and if you have the diagnosis, if you have a score above than 10. These are the antibodies for lupus. So I'm not going to talk about the labs in any details. I will concentrate on the antibodies we used to order. The ANA, the anti-double strand, the anti-Smith has the high specificity. Anti-Ro could be positive, anti-lab positive, but they give a clue in not only diagnosis lupus, but if you have a pregnant lady or if you have a lady with positive ANA and anti-Ro and anti-La, that give a clue that the patient may have cutaneous lupus or she may have risk to develop fetal lupus when she gets pregnant. And these are the blood work to be ordered in the clinic to see if the patients have a flare or not, starting by the CBC, complements, low complements, protein in urine, and high anti-DNA titer. This is what we should do for the patient as a lab test in each clinic, and to assess by history each organ from skin to CNS, going to malignancies, DVTs, PEs. Why I'm talking about neuropsychosis? Because lupus, it's one of the severe, high risk and increased morbidity, mortality for the patient. The patient with neurolupus, they can start it by simple personal change, psychosis, depression, headache, seizure. It may come simply, but the people will not give attention to it, and the patient may come later on developing multi-organ failure affected by lupus. So we do the musculoskeletal imaging, skin biopsy, kidney biopsy for nephritis, and renal also. It's important to be highlighted how to follow up by seeing the protein in urine. Okay, and we consider it positive if the patient have more than 0.5 gram per day or plus protein 3 in urine dipstick, and if the patient have granular red hemoglobin and granular. This is when you, if you see the patient in your clinic, urine analysis is very important as CBC. It doesn't have a lower importance. So then we will talk about how to assess disease activity. We have a scale. It's called the Systemic Lupus Erythematosus Disease Activity Index. We should screen if the patient is not having any symptoms, or if they having symptoms including simple skin and arthritis, going to the major organ involvements such as CNS, cardiovascular, pulmonary, renal, DVTs. So if we consider the patient in remission if the score is less than 4, and making sure that the patient is on steroid or not. So here again, the severe disease. It's not, بصراحة for me, it's not nice if I have a patient come to me and he was diagnosed to have lupus, not being on proper treatment, and came with a history of seizure or cranial nerve palsy or something serious. That it's gonna ring a bell that I missed something or the patient had progress of the disease, okay? Major organ involvement such as we can see here, nephritis, cerebritis, myelitis, pneumonitis, mesenteric, as we put a picture before, thrombocytopenia, and sometimes you can find the patient came with hematological complication, ITP, TTP, hemophagocytic syndrome also. So lupus is not simple disease. It's aggressive if not treated early, not getting targets to in treatment and prognosis for the patient. And the patients, lots of them, they can come to you in their 20s, 30s. The treatment, anybody can tell me from the audience what medication all patients of lupus should be on it? Yes, excellent. Plaquenil, unless the patient have contraindication. This is each patient with lupus, he should be on Plaquenil to prevent what? What is the importance of Plaquenil? So the Plaquenil decrease the antibodies, decrease the inflammation, decrease the flares, decrease the insulin resistance, has antithrombotic effect, and lower the lipid. So it's a criminal if you have a patient with no contraindication, lupus, not on Plaquenil. We started by this dose, and if the patient got in remission, we decreased the dose to 200. So what is the role of glucocorticoid? So in each patient with lupus, sometimes according to the organ affected, if they were patient only have skin and joint synovitis, or if the patient have hematological or pericardiac, or if the patient having major as synovitis, cerebritis, or pulmonary hemorrhage, we have to calculate what organ is affected, and we have to assess what disease severity if the patient have, because this will affect the dose that we are starting with the patient. In the clinic, we can start the patient on 20 milligram or a 0.5 milligram to 1 milligram per kg if we have a patient with skin, joint, and simple hematological, with excluding if the patient is having RTP or TTP or something critical and no other organ involvement. We use higher doses. We pulse the patient starting from mini pulse 250 to 1 gram for 3 days, and then we will continue on 1 milligram if the patient started to have what? Major organ are CNS, pulmonary hemorrhage, or glomerulonephritis stage 3 and 4. As a maintenance treatment, we can start Imuran, MMF, and cyclophosphamide according to the organ affected. But the most common used MDR treatment for the patient with mild disease. If they have hematological, we can use Imuran. If the patient not responding, we can escalate it to MMF. Cyclophosphamide is preserved for the patient who have cerebellar hemorrhage, pulmonary hemorrhage, glomerulonephritis stage 3 and 4. And sometimes if the patient, I will give you one of my cases. Belimumab also is a new modality, a new medication, started to be used in our practice if our patient not responded to mild to moderate patient not responded to the DMARD. Rituximab considered to be used in the refractory organ-threatening patient. And we don't have to miss that most of our patients may have thrombotic and antiphospholipid-related manifestation, and the patient may need to be an antiplatelet or anticoagulation. Lupus nephritis, and this, you have to know that we have 6 stages. Stage 1, 2, we don't have to treat the patient. Stage 3, 4, we used to treat them with pulse steroid and MMF, maybe cyclophosphamide. Stage 5, we consider steroid and MMF. Stage 6, the patient will need to be on renal replacement. Cutaneous manifestation, we used to start the patient on topical agent, anti-malaria, sometimes glucocorticoid. If they are resistant, we use methotrexate, dapsone, and MMF. Management in pregnancy. So pregnancy, any patient with, if you have a patient, female, young age, married, non-married, you have to screen her and you have to educate her when to get pregnant. So any lady should be in remission clinically and lab-wise 6 to 1 year before getting any pregnant. Despite that the patient is having the medication, she may have flare of the disease, and she may have preeclampsia, intrauterine fetal death, abortions, and her kid also may be affected. We have a complication, it's called lupus, neonatal lupus. It's have a manifestation. We have to discuss it with her and her husband, and we have to educate them because it's a shared decision between us and our patient. If they don't have the awareness about their disease and what complication they may have, they won't follow your medical advice, and they won't take the medication, and they will come with the morbidity, mortality. Lifestyle modification, inactivated vaccine should be given to the patient. Hormonal replacement therapy also, it may increase the risk, but oral contraceptive, there is controversy about it. So we have also to screen our patient for infections, cardiovascular risk, and osteoporosis. Osteoporosis, especially if you have a patient, even if she's young, being on steroids for years and years and years, she should be screened for osteoporosis. And there is a doctor, he will talk about the osteoporosis in details. So the prognosis, the morbidity, it depends about the disease activity, the drug toxicity, the organ damage, the quality of life. And as for that, we have to early diagnose our patient to prevent morbidity, mortality, and to let them live happily. The sources of mortality in lupus patient, it comes from the infections, cardiovascular, bacteremia. Antiphospholipid also increase the risk. So this is my patient. One, you may have it in the clinic. This is a 23-year-old female patient presented with a history of pleuritic chest pain for 3 months, had multiple ER visits. The chest X-ray was normal. Each time the patient had a history of palpitation and joint synovitis, but nobody is considering her to have a serious thing. On exam, the patient was conscious oriented, the face was pale but not jaundiced. The patient had synovitis, other examination were normal. The labs, white blood cells showed pancytopenia in form of leukopenia, lymphopenia, and hemolytic anemia. The peripheral smear showed chestocyte, creatinine, liver function, thyroid function were normal, ESR slightly high, 50, and C-reactive protein 22. The urine showed +1 protein. Serology for hepatitis B, C, HIV were normal. Rheumatoid factor was negative, anti-CCP negative, the ANA positive, anti-DNA positive, anti-Smith positive, anti-RMP positive, anti-Ro positive, anti-LA positive when she came to our rheumatology clinic. So the patient echo showed mild pericardial effusion. So we started the patient on Plaquenil, short steroid. We gave her about 20 for 1 week, and the patient improved. We started her on Amiuran, but the patient did not make that improvement. After 1 month, we switched it because she had also complication from the Amiuran in form of GI upset. Even though the patient was started on MMF, she wasn't having complete remission. She was started to have also the, still having the synovitis with improving of the hemoglobin, but she were leukopenic. After that, we started the patient on belimumab after we make sure that the patient doesn't have mimickers, things, and all Sjögren autoimmune was ruled out. The patient started on belimumab, and she is in remission right now. And these are the articles that it's all about the early diagnosis is to prevent, to early diagnose, to start the patient on the proper treatment, targeting the affected organ and decrease the morbidity, mortality, making the patient with an excellent life. And I have 2 patients. One of them, she had PE. She's lupus, she has PE, and one of them also, she was lupus and she had pulmonary hypertension. 2 of them, they get pregnant, but with the proper treatment, they had a normal pregnancy and excellent outcome, but one of them, she had neonatal lupus. Thank you.